414. How are you? All right. So as promised, I'm gonna do a lot of overview. I'm not gonna be looking at a whole lot of videos here. This is just to finish up the material that we didn't quite have a chance to get to. I do want to remind you guys, please get done with your polling questions and discussion. I'm gonna close them down today. All right. All gone. All righty. And we have an exam a week from tomorrow, okay, on the 9th. And I'll be sending out, as always, the study guide, okay? And yeah, so what else do we have going on? Check that out. Wasn't that a great picture, guys? I love it, okay? And then, so this is my favorite one, the fun one. Um, this one is the fight on one, and then here's just the tradition. Yeah, if I was your age and I was in school, I'd be sending a copy of this out to my parents. And like I said, some of the pictures I took in class, I stuck in the PowerPoint so you can access those. All right. Cool, cool, cool. So what I did is I went ahead and the PowerPoints, and this is my view, not student view, so it's going to look a bit different than what you guys take a look at. And so I scroll down here, and and I apologize. I'm going to show you what happened with the Huntington's disease and Parkinson's disease video last time. Um, I'm always editing, and I thought I'd put the updated one in, and I hadn't, and that was why we had that little hiccup in terms of deep brain stimulation. This is the ALS PowerPoint right here, and remember we got part of the way through the dementia. So I'm just going to give you some kind of quick updates here. Now, this is a pretty incredible video right here, and so I highly recognize checking out the Understanding Parkinson's video that exists in this Nature article. So, and I said 315, and I'm going to change that right. I showed it 315, and they're not at the level that I expect of you guys. So it does go into a lot of the concepts we talked about, inflammation and everything else. So do check that out. Okay. So as we were going through Parkinson's disease, we were looking at the sporadic causes. This is the term of art that you guys are going to be using all throughout your medical careers when it's of some unknown environmental cause. It's something where we're on the hunt in terms of epidemiology. Okay. Um, and so we talked about some of the environmental causes. We talked about pesticides. Okay. We also talked about the unique story of the contaminated fentanyl that was synthesized up in the Bay Area about 30 years ago, and but it really kind of broke open the whole field of what's causing Parkinson's disease. And that was because the original compound MPTP, we're going to show you in a second, is taken up by glial cells, and it's been converted into MPP plus. And the key to the story was that MPP plus looked, for all intents and purposes, just like dopamine to the dopamine transporters. So it was transported back into only dopaminergic neurons, and that's why only the dopaminergic neurons died. And then the MPP plus got into the cells and poisoned their complex 1 of their electron transport chain in the mitochondria. So poisoned mitochondria, no more ATP, calcium overload, okay, free radicals, and the cells just died, boom, okay, awesome. So back to this kind of pesticide concept here. This is another pesticide. This was actually, you see this lawsuit, another commonly used pesticide. These spray the pot fields in California heavily with this stuff, and again, it's linked with Parkinson's disease. All right, so again, here's this concept that I was just going over, and I just want to key up on this, okay? All right, so we see over here, again, the original compound, the MPTP, that, basically the drug laboratory, so to speak, the lab that was making fentanyl outside the Bay Area, the person, the chemist, was just trying to increase his yield, and so he added a couple other compounds, just more powder, more you can sell, and didn't realize that they were going to react, and they react to create this MPTP. And this is the MPTP, again, easily going across the blood-brain barrier right here. It gets sucked up into the glial cells, gets converted to MPP+, and that's where it looks just like dopamine, okay? And you see here the MPP+ gets sucked up into the terminal, poisons the mitochondria. See right here, as like it says right here, it blocks the electron transport chain. So it blocks complex 1, and you're not going to get any ATP, and you're going to generate a lot of free radicals, all right? Cool. All right, so then, you know, the other thing that, of course, that I talked about then was that the most common herbicides, pesticides that we have in the world, one of them was rotenone, and rotenone does the same thing right here. And this is, you know, a blow up of your mitochondria right here. We got out here the outer mitochondrial membrane, and we see complex 1. Again, this is how we're making, I would say over here, complex 1 is key to making ATP in the electron transport chain found inside your mitochondria, your powerhouses. You poison that, no ATP. No ATP, calcium overload, and no ATP, you generate tons of free radicals, etc. Okay, awesome. This is just another neurotoxin right here that is used in the laboratory. It's called 6-hydroxydopamine. Alrighty, so then we kind of went through, you know, a lot of other things that I did in class, and we just talked about, you know, the other new kid on the block, of course, has to do with the gut microbiome and just chronic inflammation that happens in the gut when of course, it all points to having a diet that's too high in simple sugars. And then when you have a diet high in simple sugars, then that's just going to create critters right here that are going to thrive. You have a diet that's really high in fat and red meats, again, they thrive. And you compare that to a diet that has a lot of fiber and vegetables, the Mediterranean diet, and you get different microbiota. And so they being people that do experiments, do the epidemiology, sample the gut, and then you can replicate that in animal models, and you can see that you create inflammation in the animal models. So there's a lot to this. All right. So anyways, so we went over all this, symptoms and the treatments. Okay, so we went through all here, the loss of dopamine neurons. We talked about that. I talked about exercise being important. Okay, and just also some occupational therapy they can do. We talked about cueing, etc. Okay, and then we came all the way down here, and I just want to get down here to where I was at. And we talked about the need for doing more CBD research because there are more CB1 and I mean CBD and CB2 receptors in stratum than anywhere else. So there's a lot of hope there. I talked to you guys about this, which was deep brain stimulation. Again, it's used in conjunction with drug therapies or in isolation. It just depends on the patient. Okay, and you know, as a neurologist, you guys just have to figure that out. Okay, all right. And so I'm going to get this here. This is a quick video. We're not going to be watching a lot of videos because you can do this on your own. But this was one worth watching. And this is the one I was trying to access the other day when I failed miserably. All right, so this is 2 minutes long, and so we're going to watch this patient here.
Okay, it's February 22nd, 2013. Just a couple of questions for you, sir. You started having a tremor in 2005, is that correct? That's what our records indicate.
Correct.
Okay, and you've never been on medicine?
This is 9 months.
Let's just do a few tests.
Years later.
Can you tap your left fingers for me?
So he's got really bad tremor. He's got rigidity in his right arm, so it's like he's paralyzed. Okay.
Open and close like that. Okay.
Wheelchair bound for pretty much.
Walk a little bit if you can.
You can see how much weight he's lost.
Okay.
Because of the Parkinson's, because he can't really get up and move and exercise.
Hold on right there. Hold on. Okay. Come towards me a little bit.
Really bad gait.
Right. Let's turn around and go back.
See his facial expression, okay? It's called masked face.
Okay, sir. So can you tell us the date today?
Today is October 16, 2015.
Okay. And so we've been kind of gradually increasing your medicine over the past couple years, and you've gotten a lot better, haven't you?
I really have.
Okay. Well, let's see you try to do some tests that you had trouble doing last time. Can you tap the left fingers like that? How about the right? Okay. Oh, great. Now let's see you walk. I'm going to open the door here. Okay. And can you walk towards that door?
Yeah.
So you can see how much better he is. He's gained weight because he's getting out there exercising. He's a combination of meds and deep brain stimulation.
Okay, and turn around. Can you walk like this, heel to toe, like you walk in a tightrope?
All right, pretty awesome. All right, cool. I just wanted to get that in. I did have it, guys. I just screwed up in terms of the post. Okay, so this is right here, a number of articles that talk about, again, this concept of using both deep brain stimulation, okay, and L-DOPA therapy. So it's a concept of again, getting the best yield, the best outcome. All right, and so what's coming down the pike? So there's more and more interest in DBS, deep brain stimulation, but also maybe we can start looking on a method that's not going to be so invasive. That's transcranial magnetic stimulation. Okay, this is kind of like what exercise did. Okay, so exercise, what we did is we bypassed the lack of dopamine. So what the concept is here is we can bypass the lack of dopamine by stimulating the pathways that don't involve the basal ganglia, and that's the goal of deep brain of transcranial magnetic stimulation, and this is just kind of a sad statement. Okay, it's 2017, and how insurance payments. Okay. It's a big issue. Insurance companies don't want to pay for deep brain stimulation, all right? It's $80,000 for the initial surgery, okay? And then $10,000 required every 3 to 5 years for replacing battery implants under the skin, like I talked about, all right? All right, so that's kind of it on Parkinson's, and you can go back and look through the rest of that, okay? Well, one last thing. So we're going to be talking, in the end, we talked about some issues, that happen, with Huntington's disease, and that there is an issue where, it's a devastating disease, and this kind of right to life issue that pops up. Okay, I'll talk about that with respect to amyotrophic lateral sclerosis. Okay, all righty. So I'm not going to even say that. We're good. All right, cool. All right, next. Okay, so then we were doing Alzheimer's disease, guys. Okay, and we got chugging along here. We didn't get as far as I would have liked to. Okay, but we were emphasizing the fact that there are other aspects of dementia-like symptoms that have to be ruled out. So I do want you guys to remember this in your practices. Your projects have already launched, okay, but just in terms of your thinking, you guys are neuroscience majors going on to becoming healthcare practitioners, is you got to focus on what's reversible, okay? And so that's where we're at right here. These are all the reversible dementias, okay? And we kind of went over that in class as well. Okay, we went over the cost, we went over the epidemiology, we went over the very issue that most of dementia is late onset, okay? And when you look at late onset, most, as I indicate right here, are sporadic, meaning environmental causes, an accumulation of damage from things like head injury, toxins, okay? And there's we're grouping the sporadic into just having leaky blood vessels, which I think I was talking to Romano about this, and it's a big deal in terms of thinking vascular etiology and diabetes and risk. Okay, all right, so we went through all these and talking about diabetes right there, bump, and this is the vascular risk. We talked about risk factors, okay, modifiable, okay. Risk factors are all over here on the right, all things that are going to improve brain function. And then these are kind of disease risk factors over here, but they are also modifiable, okay? That's the point of this, okay? All righty. Just because you have type 2 diabetes doesn't mean you can't just clamp down on your diet and start exercising, right? Okay. All right. We then went over how you're going to diagnose it, okay, and a mini mental status exam, psychological analysis, psychiatric analysis, neurological. Imaging would be great, but it's too costly, okay? That's done in clinical trial scenarios only. We were watching this patient that was being screened right here by the mini mental status exam. Again, these would be the three, I mean, the 10 signs that you could use, an example of what you would be using in your diagnosis of your patients. Okay, and this is put together by the Alzheimer's Association. And if we just go in there, we can kind of take a look at these in greater detail. Okay. All right, so we come over here, and again, you're going to look at, we see that we have memory loss, okay, challenges in planning, solving problems, difficulty completing familiar tasks. You're going to be dealing with not just the patient, because they may have a lack of awareness. You're going to be dealing with the caregiver, confusion over time and place, on and on and on. So these are the kind of things that you'll be looking at right here. All right, how funny! It's that time of day. We get a bird that taps our window. Okay, I'm going to show you right over here. It's just animal behavior at its greatest. That's our front window. So he comes and sits in the bush, and he sees his reflection, and he attacks his reflection, and he does it every single day. I can hear it in the background right now. Oh my God. Okay, I don't know if you can hear the click he made. Let's see if we'll do it again. That's him. He flies back in the bush, and then he attacks himself and hits the window. He's been doing this for about 5-6 months now. Okay. Love it. All right. So we look at this woman. Okay. The maximum mini mental status exam is a 30. Okay. And then there's this rating scale. All right. So 2024 is mild dementia. 30 to 20 suggests moderate dementia, and less than 12 indicates severe dementia. So her mini mental status exam was about a 12 to 13. So like the psychologist said, and he was part of the clinical team in your Alzheimer's clinic, she's severely impacted. Okay. All righty. So then as you're going down, this is, again, the mini mental status exam, the type of questions. And you'll be from history of first getting trained in a team and doing yourself hundreds and hundreds of times. Then you have this qualitative scoring based on their approach. Okay, and again, this right here again shows you the rating based on the final scoring, going from 0 to 10, from 25 to 30. Okay. All right, and I just want you guys to be able to check that out, okay? So you're gonna have to then, because there is not a blood test that's gonna say anything, you're gonna be, evaluating the mini mental status exam, and then you want to be able to say, hey, is it a dementia caused by these? Obviously, with Parkinson's disease, you're gonna have a lot of motor problems, okay? And also, your neurological exam, you're gonna be able to say frontotemporal is a little bit different, okay? And so what you're going to do is you're going to take that mini mental status exam, okay? And so you're going to have the outcome, so mental status, symptoms, okay? You can give some psychiatric analysis. You're going to do some neurology. If you have money, you could do some imaging, okay? And then we could then assign what kind of underlying cause of the disease is, okay? So is it Alzheimer's disease, okay, AD? Is it frontotemporal dementia? Is it diffuse Lewy body disease? Is it Creutzfeldt-Jakob disease? Sorry, or is it vascular dementia? This is just kind of an example of what you would do, okay? In the future, okay, we hope, and this is kind of in the future biomarkers, to be able to do sampling. Maybe we could do cerebral spinal fluid sampling and look at the levels of this protein right here. And this is, the protein that is either the horse or the cart of Alzheimer's disease, and that's the 42 amino acid length amyloid beta peptide, okay? Could we do PET scans? I mean, it is a very doable thing where you look at the amount of amyloid deposited in the brain. Too costly, okay? Maybe the cost reductions will happen, okay? Cerebral spinal fluid analysis of tau, which is the other cause that we're going to be going over, okay? We could do glucose utilization. That's what fluorodeoxyglucose means, okay? And of course, then we have cognitive impairment. But you see over here, cognitive impairment in terms of time is one of the last things. So the concept is if we can go after these biomarkers and get them very early on before you start even seeing the cognitive impairment, okay? Then maybe we can do some preventative measures, okay, that will slow the progression as new meds develop that might reduce this. That's the concept, okay? Alrighty, cool. And then we come over here, okay? And what's another big biomarker? Okay, we know that so much of disease is inflammatory. So maybe we can use something like, excuse me, C-reactive protein. Okay, measures the oxidative stress. Okay, things like that. Okay, so inflammation is likely an underlying cause, and what we need to do is see what kind of links it can be made on that. Again, here's a PET scan. Okay, again, it's super costly. Okay, so these are just looking at amyloid and tau. These are the two different proteins that aggregate because they are not consumed, okay? Remember the whole autophagy, okay? And then the proteasome, that is the turnover of proteins. Well, these guys accumulate and become toxic, okay? And so we can see right here, this is a normal adult patient looking at their tau and amyloid. This is actually somebody that can, and this is the confusion in the field. Certainly, we see a lot of amyloid and tau pathology in Alzheimer's patients that we see right here, but you can have somebody that has completely normal cognitive function for their age group, and then they die and donate their brain, and you go, oh my God, look at this, okay? Or they're part of a study like this. This is a PET scan where we can look. PET scan allows us to radioactively label compounds that would bind to the amyloid or the tau, okay? Alrighty, you can see the shrinkage of the brain right here, and that's what a pathologist would do, and that's what this is all about. We can then talk about the different risk factors. Just like everything else we've talked about in this class, there's the modifiable risk factors, and then there's the genetics. Okay, alrighty. So we're going to get into this etiology, genetics and environment. Okay, this is something we already discussed. Okay, again. Late onset is predominantly sporadic, so there's maybe something that we can modify. These are the ApoE. It's a risk. Okay, it's your cholesterol-carrying proteins. We all have ApoE. If I could have it and still not get dementia, but it increases the risk. All right, and then these are the autosomal dominant forms that give us lots of amyloid beta and lots of tau. Okay, awesome. Okay. What else do we have? Okay, so we have genetics, okay, family history. Do you have heart disease? Do you have diabetes? Okay, these are now risk factors. I talked about the ApoE allele just a second ago, okay, and then we have diabetes, and we have and vascular disease, okay? Alrighty, so this is a couple studies looking, and what I did is I just showed you my Google search page, capillary inflammation causes dementia. Boom, you get a ton of stuff, okay? Impaired perfusion, okay? This is the article right here, in capillary dysfunction in prodromal, and it is the period between the initial appearance of symptoms and the full development of the disease. So this would be early onset that we're having capillary problems, vascular problems, diabetes, stuff like that I've talked about, okay? Alrighty, here's some modifiable risk factors, okay? Level of education developed, okay? It's basically your brain gears up resources if you use it a lot, okay? Diet, exercise, sociality, okay? And it's actually better not to go through what's called senescence, where you have a wasting away of muscle and bone. So it's best to maintain some body weight as you get older, okay? All right. All right, so a really interesting aspect of science is, like I said, is the epidemiology. This is a great article from the Wall Street Journal about hotspots. Where is it happening? And we see clusters down here. Something's going on now. Certainly, people migrate down here, okay? But this is going to be a per capita based on age as well. There's still greater hotspots. You see down here, the prevalence is much higher down here in Texas, New Orleans, and Florida, okay? Um, and again, you're able to do the analysis of patterns based on populations, and this is all about right here. Okay, we see that that when you have education tapped in, we can look at Black, Latino, and white. Okay, and how that taps into prevalence. Okay, we can see poverty. Exercise. And again, it's, I just encourage you to kind of look at these and see how these social octave factors tap in. Like I said, the very same approach is used for looking at cancer clusters or cancer hotspots. Okay. All righty. All right. So these are the steps you have to take to maintain really good cognitive health, okay? And to reduce your risk, okay? So these are your modifiable risks, okay? So exercise, eat healthy, sociality, keep active, okay? Control your diabetes, control your blood pressure, on and on and on, okay? Don't drink too much alcohol and try and get some sleep, right? Alrighty. And, okay, if you see right here, stress. We talked about this early on. Cortisol, elevated cortisol, okay, causes diabetes. Elevated cortisol causes degeneration in the hippocampus and the prefrontal cortex. We went over that earlier in class, okay? Awesome. Alrighty, let's continue on. So we looked at these kind of epidemiology, some of the modifiable risk factors. The original gangster was looking at plaques and what are called neuritic tangles that have this abnormal microtubule protein called tau that stabilizes the microtubules. Okay, so we can look at these genetics. Okay, and so in this article, it just kind of lays out what they all do. All right, so we have amyloid precursor protein, and it's located on chromosome 21. Okay, and then this amyloid precursor protein gets processed. Okay, gets clipped into these different active components that are actually used for growth factors that help the brain work. Okay, that's the whole plan with this. Okay, so we have a first clip that is done. Okay, so we have a beta secretase, we have an alpha secretase, and we have a gamma secretase. Okay, and it's going to create these different length aggregates. Now, if you have too many of these coming through, like chromosome 21, even though they're normal length of about 40 amino acids, they just by mass action they aggregate, and this is why people that have Down syndrome, which is trisomy 21, they've also developed Alzheimer's disease. They have massive amount of plaques in their brains. The other thing that happens is this gamma secretase, okay, can actually clip at the wrong level. And as a result, instead of having mostly this 40 amino acid segment that our brain uses, you get a 42 amino acid segment that is dysfunctional and causes the beta amyloid segments to stick together and form these toxic, what are called oligomers. And those unto themselves cause free radical damage and cause calcium overload. And then in the end, they form these big plaques that are pathological as well. All right. The other genetic mutation is in the actual amyloid precursor protein. Okay, so there's three big mutations in terms of the genetic mutation. All right. So the ones with the clipping of the gamma secretase is called presenilin 1 and 2 mutations. Alrighty, so we have, what's the background we've talked a lot about in this class, okay? So we have normal amyloid precursor protein, okay? From aging, okay, it's going to cause aggregation because of protein turnover goes down, protein processing goes down, okay? Things are improved with adequate diet and metabolism. Bad diet and metabolism causes bad elements to enter the brain through the vasculature. Okay. ApoE is not only important for carting around triglycerides and and cholesterol, but it's super important at actually getting rid of the amyloid beta once it's been sent out and used appropriately. And so what happens is the EPO-E4, the APP, is not removed as quickly, okay? And then the mutations that are the big focus. When all these factors are being considered, you're going to have either altered production of this A beta 42 amino acid. Again, 42 is the toxic one. 40 is okay. 42 is toxic, okay? And so it's altered either production or clearance. In the end, it results in huge plaques that form, and it's thought that the amyloid beta also triggers the formation of the tangles from the altered tau protein. All right, and that's what happens. Okay, the brain shrinks, and you're in bad luck, bad shape. Okay, all righty. So what do we see here, my friends? All right, so again, it's this cycling, okay? Again, clipping by beta secretase or in gamma secretase. And the problem has to do with mutations, okay? So there's a mutation in chromosome 21, okay? Where the APP that is produced when it gets clipped produces the 42. That's a bummer, all right? All right, then we see there is a mutation, okay? In chromosome 14 and in chromosome 1, these are they change the gamma secretase. So now normal APP is produced, but the enzyme that processes it clips at the wrong one and makes more 42. Okay, again, A beta 40 is a good thing. We use it for growth and repair. A beta 42 is toxic, just like that. Okay, so that's the concept with that. All right, so this is a good video for you guys to watch, put out by Roche. We already looked at it once. You can look at it again. Here's more videos, again, that go over this process of this beta secretase right here producing beta amyloid 42, okay? So the secretase clips the amyloid precursor protein, okay? And then this right here goes a little bit deeper into the phosphorylated tau. All right, cool. All right, so then I hammer away about 42, okay, higher levels of 42, all right, that's a bad thing, okay? And so there's plenty of articles about this. Okay, there are, as we said, multiple forms of dementia, Alzheimer's disease, and then this is frontotemporal dementia. In frontotemporal dementia, you get a lot more of the tau, these are called PIC bodies, okay, than you do the plaques, okay? So the phosphorylated tau, the abnormal phosphorylated tau, it accumulates, and it accumulates mostly in the frontal cortex, okay? Can you detect that with the test? No. Can you detect that when the person dies? Yes. Okay, but what you can do is you can do the rigorous behavioral analysis, and we'll see the difference between frontotemporal dementia is a different beast in terms of the behavior. Okay, all righty. So what's going on? Okay, so we see that a striking characteristic of a mutation in chromosome 17 for frontotemporal dementia, okay, is that that it has extensive tau pathology, okay? And abnormal amyloid beta is not a characteristic feature of this disease. So again, it's a difference, okay? Heavy tau pathology in this. And there is a form of frontotemporal dementia associated with amyotrophic lateral sclerosis as well, okay? So you get this kind of mixed dementia from those two. Okay, alrighty, so it's a way of kind of defining based on pathology, and that's what I'm talking about there. All right. So we have Alzheimer's disease, okay, with mostly plaques, some tangles, and then FTDP with the chromosome 17 mutation that has, you see, reduced plaques. It has some reduced plaques, but magnified tau pathology. All right. And that's what this figure is all about. And here's the paper that talks about that. Okay, so we're just kind of racing through. This is all just kind of set up history. Okay, I'll come back here. Okay, so late onset, a lot of no genes associated with it. We just went over these autosomal dominant forms. Okay, the presenilin 1, the presenilin 2. Okay, the autosomal dominant form of abnormal APP found in chromosome 17, 21, sorry. um, very rare, 3% of the cases, okay? Um, and then we see there is about almost 30% that are this familial risk. It doesn't mean you're going to get it, okay? These ones mean you're going to get it, this autosomal dominant. This, well, you may not get it. And again, this is autosomal recessive. So the greatest risk is if you get ApoE4 from mom and ApoE4 from dad too, okay? You may be E2, E3, you're looking pretty good. E2, E2, you're the best ever, okay? That's how it all plays out, okay? So this is kind of looking at the population, okay? And we see that ApoE33 is the dominant, okay, allele in human populations. It's the dominant form, 64%, okay? We can then kind of look around the horn and look at how things mix up. Look at ApoE2, T2, okay, 1%. That's one. It's like super protective, super great cognitive longevity, okay? And then we see here E4, 5%, okay, of all of humanity has that, okay? All right, that's just looking at us. But you see that 5% makes up a 30% risk, okay? So that's the way you would look at that. All right, cool. And then these are just other kind of associations in terms of familial auto-recessive inheritance of the ApoE gene that carries around cholesterol. Now, the other thing that it does, okay, so this is ApoE4, okay, we're talking about. Again, maybe I'm E3, okay? So this guy is a major cholesterol carrier protein. We talked about that, remember? It was the exchange protein that we saw when we watched the balls of cholesterol and lipids cruising around through our bloodstream, okay? And then this is the blood vessel right here, okay? And what it also does is it will make its way into the brain and it will then collect up A beta, okay? And then it allows it to be processed and removed, which is awesome, okay? But if you have more E4, you're not very good at collecting it. And that's the bottom line right there, all right? And okay, so that's what that's all about, okay? All right, so what are we looking at here, okay? So this is right here looking at vascular risk, okay? Um, and then we can just launch straight into treatments. And I was looking at your guys' websites, which are awesome, all right? And I saw that you guys listed very clearly the standard care of treatment, okay? One is what are called acetylcholine esterase inhibitors. This is an enzyme that gets rid of acetylcholine. Acetylcholine is kind of like a volume control, okay? And the other one right here blocks glutamate toxicity. That's the idea, and improves the signal noise, and that's in Namenda, okay? All right, so this is, again, the concept of these acetylcholine esterase inhibitors. So we're going to look at these medications for memory loss. This is from Alzheimer's.org. All right, this is an acetylcholine synapse right here. And the cholinergic nucleus, which is located right down here, sends axons all throughout the cortex. It is like volume control, increasing your ability to focus, look at the signal versus the background noise of anything you're thinking about all throughout the brain. That's the concept there, okay? Alrighty, so what happens is you release acetylcholine, okay? It improves the circuit's behavior, the glutamate circuits that are, thousands of synapses all working in conjunction to bring back a memory, to retrieve it so you can act upon it. And then it's terminated, okay? There are no transporters in cholinergic neurons. There's this enzyme, though, called acetylcholine esterase right here. And what it does is it degrades acetylcholine into choline and the acetate group right here. So this is choline and acetate, okay? The acetylcholine esterase inhibitor blocks this enzyme so that it doesn't degrade and the acetylcholine stays around longer. So that way the volume stays around longer. And then these are the drugs that are the current market of acetylcholine esterase inhibitors. Awesome, okay? This is the other one, okay? This right here is Namenda also is the drug name, also known as memantine, okay? So So the problem, the idea is there's too much glutamate being released in an inappropriate fashion in the Alzheimer's brain, and you can't pick out the signal from the noise, and it could be excitotoxic, okay? So the idea is that we're going to give you this low affinity NMDA receptor antagonist called memantine, okay? Also called Namenda. And so the key being low affinity is that when you're just having this abnormal background release of glutamate, that could be the underlying cause of Alzheimer's, just like it is possibly the underlying cause in amyotrophic lateral sclerosis, is that you're going to get rid of the noise, okay? And then when in comes a signal and you have more appropriate release of glutamate, because this thing is low affinity, a bolus of glutamate, boof, from a signal is able to kick the Namenda off, and so now you have a real nice signal. So you have this improved signal to noise, and lo and behold, you can retrieve a memory. Lo and behold, your behavior is produced, and that's the concept with that. Okay. All right. So okay, this is a great YouTube about again managing Alzheimer's disease with these different types of acetylcholinesterase inhibitors right there. Okay. And then from there, we went to the clinical trials. Okay. And there was lots and lots of hope of a monoclonal antibody that we would infuse into the bloodstream, so intravenous, okay, and that it would be able to suck the amyloid beta from the brain into the blood and then capture it in the blood by that antibody, and then it would just then be degraded by the kidney and liver. Lots of hope, lots of promise on that. And so what happens was it got fast tracked, and then lo and behold, it really didn't work that well. So it got FDA approved just this last year, all right, and it was all the rage, and then lo and behold, there was not complete honesty in terms of the manufacturer about what was going on. And so about a month ago, the FDA came down on them and said, this is an experimental drug. This is no longer FDA approved for general use in the population, and it can only be used for clinical trials. So they've kind of back to the drawing board that it is now only a clinical trial drug until they work out the bugs. Because what happened is 40% of the patients that were using this approved dose of the antibody experienced brain swelling and bleeding, okay? And the other thing that it said right here is this drug, okay, which is Aduhelm, okay, Aduhelm, I don't know what it's called, but anyways, did not show any benefit. And that's what it's talked about right here, is there was almost next to no benefit. So you had brain bleed with very little benefit. Bullshit. All right, cool. All righty, it's a tough time. And here's more and more stories about drugs not working out and clinical trials stopping, right? So we see here Pfizer, Johnson & Johnson called off the use of drugs, and Pfizer has completely stopped doing any research in Alzheimer's disease because it's not cost benefit for them. You can work on a drug for 10 years and have it not work, and versus a cancer drug that you can work on for a very small amount of time and get an immediate return on your investment. So these are just more clinical trial studies that are ongoing. And then lastly, this is the one that we talked about in class. That is I particularly think is a really exciting clinical trial. And this is again down here, where what it is the GLP-1 agonist, okay, that is going to remove glucose from your blood. So it's used for diabetes. It's been successfully used for diabetes for a number of years now. And then they started noticing, hey, wait a minute, normally diabetic patients get Alzheimer's disease, but the diabetic patients that are on Ozempic or Trulicity or all these other GLP-1 agonists, they're not getting it. And so now they're doing true trials on this stuff, and I think there's a real future for that. So I'm pretty excited about that, guys. What else do we have, man? We have exercise, we have cognitive engagement, we have diet therapy, we have dietary intervention, and we talked about this the last day of class, that there, again, There's always this like this has to work based on all the mechanisms we've always talked about. They did a big trial and they found that it did work. Okay, and it was most effective in women. This is remember the very beginning of class, the music in the brain. Okay, so yeah, so it's pretty exciting time I think moving forward. All right, so this thing goes through all the other types of dementias. Okay, remember your reversal dementias. I've been hammering home on that. Okay, um, could it be just a urinary tract infection? So yeah, my dad had bad dementia, and he just basically had a kidney stone that was in his kidneys, and once they cleared the kidney stone, he got better. All right. These are other forms of dementia, okay? And so what we do is we can kind of like aggregate them. So we see it out here, chronic traumatic encephalopathy, and this is from multiple head injuries, or just an acute traumatic brain injury, okay? What else do we have here? Vascular dementia. These are all the same drill. It's a breakdown in the blood-brain barrier. The immune system gets into the brain when it's not supposed to, and boom, we have major inflammation, all right? All right, so this is something you guys are very familiar with now. We're looking at MRI, okay, right here, or a CT. This is an MRI, and then this right here is a perfusion CT on this side. And we could see the at-risk area, okay, and then after the clot was dissolved right here. So this would be the ischemic core. This is the penumbra, and we see when the blood flow was resumed, how you got back to a good state, okay? All right. So you're going to rule all that stuff out. Rare, rare, but we do all have prions. They are weird entities. They're not a bacteria. They're not a virus. They're little bits and pieces of protein, okay? Proteinaceous particles is what they call them, okay? But they do have this ability to replicate, and sometimes you get it not acquired, but it's just within you, okay? And then there's the acquired types as well, okay? Then lastly, we have the ones that are associated with alpha-synuclein, okay? And alpha-synuclein, remember, was the key aggregate protein that we see in Parkinson's disease right here. But there's also forms in the cortex when you have that kind of dementia, right? Lewy bodies is an aggregate of the alpha-synuclein, all right? So, and you can see that it has a prominent frontal cortex function up here in the top, okay? And it can have different presentations. It can have Parkinsonian with it, okay? And you can treat some of the with the Parkinsonian drugs and the cholinergic drugs as needed, all right? And this is just again showing you the pathology and when we're looking at Lewy body disease, all right? Cool. And you compare that to Parkinson's. See, Parkinson's is mostly down here in the nigra, later in the cortex, and we see the pathology in terms of Lewy body dementia is equal in the cortex. All right, cool. All righty. And this is the pathology of the Lewy bodies, okay? Again, the alpha-synuclein right here, okay, gets processed wrong, and you get the aggregates. Down syndrome, okay? Again, that's too much amyloid precursor protein. It's the ones that are being made are normal, but you get 3 times as many copies because of the 3 chromosomes. Korsakoff's, this is a metabolic disease. Vitamin B1, thiamine, okay? And we talked about this, and this is because you have really poor absorption of thiamine when you're an alcoholic, so you treat it by giving people alcohol. By giving alcohol, I'm getting tired, guys. Alcohol, you treat alcoholics with vitamin B1, okay? It helps, all right? And then this is the ALS, okay, frontal temporal, and it has a unique pathology. This right here is an ALS patient, an ALS, a frontal temporal patient that has really unique behavior. Again, frontal cortex is more behavioral and decision making. And this guy is a classic case, super young, okay? And you'll see that he has kind of childlike behavior.
Dementia is a problem of the elderly, right? Generally, that's true, but there is one form of the disease that can strike people when they are very young, in their 20s or even their teens. It's called frontotemporal dementia, or FTD, and while rare, it devastates lives by rapidly turning young, vital people into those who need constant care. More from Mayo Clinic.
And we were seeing our son disappear before our eyes, little bit by little bit.
Sue and Bill Bishop are watching a disease called frontotemporal dementia, or FTD, consume their son Brad. The brain disorder with no cure is changing him from a caring young man with a bright future into a person whose behavior is erratic, childlike, and at times inappropriate.
Who is it?
I don't know, let's check.
Who is it?
So you can see this is, again, this is autosomal dominant, tau pathology, chromosome 17. Okay, very unique. And you can see, the kids, this poor guy is, in his late 20s, early 30s, however old he is, and he acts like a little child.
I'll have to see who's calling.
Who is it?
It's not Brad. It's Brad's body. Of course, even that's different.
Brad's first symptoms were subtle personality changes. He'd forget to return phone calls and emails. He'd act childlike in public, and he grew self-centered, a trait his parents say was completely out of character. And as the disease progressed, symptoms got much worse. Brad became agitated around people, and he couldn't control the urge to eat.
So we literally had to put locks around the fridge and freezer.
For more than a year, doctors did not know why this was happening.
When we were told that there was something rapidly, progressively attacking your son's brain, and we don't know what it is, I lost it.
Just going to check your reflexes here.
Then the Bishops met Mayo Clinic Dr. Brad Beauvais, an FTD specialist.
That's when we started.
So you can see how tragic it is for this poor guy, and it's only going to get worse over time. So that's, again, we saw the old woman being interviewed, okay, with her memory problems, and then you can see the behavioral problems here, where he is compulsive, okay, his decision making is off, acts childlike, and that's the difference between the behavioral differences you'll see between the two forms of dementia. Okay, alrighty. Again, like I said, Creutzfeldt-Jakob, another one, incredibly rare. But you could specialize in this someday, okay? And it has to do with these prion proteins that cause. In pathology, if you were to do analysis MRI, you would see these big, giant vacuoles, and so they call it spongiform dementia. And there's the sporadic, okay, that we all can have, okay? There's hereditary, incredibly rare, okay, where you produce too much of these proteinaceous particles. And then there is the acquired, which is mad cow disease, and which made all the rage way back when, okay? So that's bovine spongiform encephalopathy. All right, cool. And I think we're done with this, okay? This right here, okay, one last thing. So this is such a cool study, the Mind Study at UCI. This video is 2014. It's a 60 minutes document, so it's pretty long, but it basically says the bottom line is like I said in the beginning, is everybody has amyloid plaque pathology, but it didn't mean they were going to have Alzheimer's. And their final outcome was the bottom line difference was that it was vascular. All right, that was the better determinant of whether or not somebody was going to have Alzheimer's disease. So I thought it was pretty cool stuff. All right, cool. All right, let me just move this guy over here. All righty, cool. All right. Lastly, amyotrophic lateral sclerosis. We didn't get a chance to do this, okay? And you can see, 1 in 400. Remember, every 2 to 3% of Parkinson's patients. Okay, so there are 2 to 3 per 100 people in our country over the age of 65. 1 in 4 over age of 75 in Alzheimer's disease. So this is a pretty rare disease, what I'm getting at. Okay, there's a couple of genetic mutations that are the most common familial form, but there's a lot of other genes that are coming in that are looking that they're good identifiers at risk. Okay. So see right here, 50% of patients with ALS die in 30 months. So it's a really horrible progressive disease. If you have a lot of money and a lot of support, like Stephen Hawking's, he was totally unique. He had it for 55 years. He died at age 76. Okay, it's multiple system atrophy and degeneration, not just the motor neurons. The motor neurons are the ones that pop up first. Okay. Alrighty. And as I said, 3 to 5% of ALS patients, they also end up with frontotemporal dementia. Okay. Okay. So what are we looking at? Okay, risk factors. More men than women. Um, this is an odd one, but people that have high levels of fitness, okay, a smaller BMI, okay, are at higher risk. Okay, smoking, diet low in antioxidants, all the usual suspects down here in terms of environmental risk factors, and a big one is head injury. So more football players and soccer players get it than people that are not in those sports. Okay. Alrighty. Um, there was a unique outbreak, okay, where the prevalence was 100 times higher than anywhere else in the world, and it was found out that it was in Guam, and the people were exposed to this form of bacteria in lakes, and it ended up being just like glutamate. So that was where the whole excitotoxic theory came out, okay. And then one of the key drugs that is used to treat ALS, Riluzole or Riluzole, is a glutamate receptor antagonist. So there is kind of an agreement that there is an excitotoxicity. These are the two most famous genes. The SOD1 gene is mutated so that you get a lot more free radical damage. And then this one right here has a lot to do with protein processing. So and so it creates this huge instead of we heard triplet repeats in Huntington's disease, this is a hexanucleotide repeat. And it just means that that the protein gets big and it gets stuck in the lysosomes, and you can't have autophagy. All right. What else we got going on here? Just the motor neurons themselves make them at risk. Okay. So they're big cells with long axons. Okay. And that means they have high levels of mitochondrial activity, lots of neurofilaments and protein processing. Okay. And for those patients that have it, they went in and they look at them, they tend to have fewer calcium binding proteins. Parthobin and calbindin 28 are both calcium binding proteins. And so they have less buffering, intrinsic buffering of the calcium when it comes in. And there's a different expression of the AMPA receptors that lets in more calcium. So all put together puts it at risk. And then we see, again, this free radical damage associated with SOD1 in problems. All right. Okay. What it is bizarrely, they have more SOD1. So, but what happens is because they have more, and everything has to be perfect, more SOD1, that makes them, they make more hydrogen peroxide than the other enzymes can take care of. All right. So you have more hydrogen peroxide being pumped out, but then the glutathione peroxidase and the catalase can't keep up with it. And the hydrogen peroxide then reacts with metals like copper, metals like iron, and boom, you got hydroxyl radicals, and it kills off the cell. This is called a gain of function or gain of toxicity mutation in the SOD1. Okay, and it causes all the things that you should read right here. Free radical damage, oxidative damage, axonal transport problems, excitotoxicity, And so this just shows you the progression of both upper motor neuron and lower motor disease. Okay, every patient's different, and in terms of whether or not you have full upper motor neuron and lower motor neuron involvement. In the end, though, in the end stage, you can see this massive atrophy of the muscles from the loss of the lower motor neurons. All right, so these are all the genes that have been found. Okay. That are suspect or risk genes, okay? These are the two big ones that are most of the cases. And again, go back, genetics only make up about 5% of the cases, okay? So I mean, it's all good to be looking at genetics, but the reality is it's mostly sporadic, okay? All right, so we're looking here again at all the different places that we reviewed in class that are associated with ALS. All right, so we have hyperexcitability, okay? We have protein homeostasis dysfunction, oxidative stress, okay, bad autophagy, accumulation of proteins, on and on and on and on. That's what this is all about. So I kind of highlighted what you should read right there. All right, symptoms and diagnosis, okay? So these are the symptoms. You have cognitive impairment, but big motor problems. So problems swallowing, all right, problems talking, okay? So you have, so it's called dysphagia, which is the swallowing problem. Dysarthria is difficulty with speech, and it's a motor issue. It's not Broca's, it's not Wernicke's, it's the actual motor neurons contacting the muscles in your mouth, vocal cord, etc. Okay, and then you have all these muscle problems. Breathing is an active motor, process where you have this conscious control of breathing from the upper motor neurons to the lower motor neurons to the muscles that, the intercostals that expand and the diaphragm that contracts, that expands your lungs. And so that becomes a problem. So you have major respiratory insufficiency, and that's why people that have ALS end up eventually having to go on a respirator. Okay, atrophy, weakness, spasticity. This is the progression. It starts with spasticity, and then you get atrophy and weakness. So these are two really great videos, and they go over this whole process in terms of what's going on. This is an amazing case study of a player for the New Orleans Saints, Steve Gleason, that actually got ALS from head injuries. Okay, so we see this muscle weakness, atrophy of muscles. You have a change in reflexive control, all right, because usually your upper motor neurons descend and control reflexes, so they're not too strong. So you get this hyperreflexia when they're gone. And then when you lose the innervation of the muscles, you get what are called fasciculations, okay? The spasticity, okay, gets progressively worse over time. And spasticity is where you look at this kind of clenching, and also when you hit, because remember Parkinson's, you can have the spasticity, and then also when you do look at reflexes, there it causes this kind of spastic hyperreflexia. All right, cool. So what are you going to do? You're going to do the neurological exam to characterize this. There's a good YouTube video here that how you would look for changes in reflexes, okay? Hyperreflexia, clonus, which is the clamping down, okay? Different types of signs, okay? You can look for fasciculations by doing electrophysiology, and these are abnormal spontaneous contractions that happen in the muscles. You can do electrophysiological analysis of the muscles, nerve conduction velocities, where we talked about that at the very beginning of class, okay? And you can rule out other conditions by doing an MRI and looking for what parts of the brain are undergoing degeneration. Okay, so these are the drugs. This is the one that has been FDA approved for a little while. It's called Riluzole or Rilutech, okay? How does it work? It blocks sodium channels, so it decreases the excitability, hoping to get rid of excitotoxicity, and it blocks the NMDA receptors, as we see right here. So it's a combination of the two, okay? Okay, this was the newest kid on the block, okay? And it's called Endeavorone, or also Radicava, okay? And we see that it's thought to act as a free radical scavenger, okay? So it's supposed to reduce the level of oxidative stress, okay? It doesn't work that well, okay? These are two drugs that do not work that well, okay? It's also being tested, right? We see right here in the clinical trials for both, also for Parkinson's disease. Alrighty, so this is just changes in terms of the function of your nervous system and how it affects the muscle, and we see all the the usual suspects: reactive oxygen species, reactive nitrogen species, pro-oxidants, okay, strewn with the electron transport chain. It's drivers of all these diseases, okay, including ALS. We see right here. All right. So this is a paper that was focusing on ALS, and you can see all the degenerative changes. I'm not going to go into that. Okay, so and then lastly, As is the case for Huntington's disease, as is the case for a lot of diseases where it's progressive, we have to ask ourselves about death with dignity. And so this is it's a moral and ethical question you'll be having with your patients. In the state of California, you can, as a physician, you can remove respiratory support, you can remove feeding tubes, but you cannot give them an excessive dose of opioids. The person has to show capacity, so they would have to go. You cannot do it in your facility. You would have to send them home. They can then get a prescription for the opioids. They themselves then, with capacity, can have their deaths with dignity, compassionate suicide. So anyway, these are all some things to think about. Wow, that was a long lecture, but I just wanted to get it done. I did it. All right. So now what I'm going to do is I'm going to save this video. I'm going to say peace. You guys have a great finals week. And what we're going to do next is we're going to put together the study guide, and then you guys will do just fine on the final. All right, guys. That's it for now. Take care.